you can be free. If you speak about the definition of the crash syndrome, first of all, it's a long local compression of any kinds of our patient's body. For example, I ask my students when we have this topic nature here, native here in our classroom, if you sit 3 or 4 hours in the classrooms on your gluteus muscles, can we name this long sitting like a long compression? Like a long compression, for example. Yeah, too much of my students answered me, yeah, teacher, because we sit so long time, we are so tired, and we want to relax. First of all, let's decide what does it mean long and high compression. Your pressure on your gluteus muscles when you sit in your, now you sit in your apartments 40 minutes depend by the weight of your body. And finally, power, which pressure it on your gluteus area, dependent by gravitation and dependent by the weight of your body. And if we, by physical methods, decide how much of newtons pressure it on your gluteus areas, we understand that this pressure is not so high and 3 or 4 hours is not so long for change any biochemical and physiologic changes like a crash syndrome. If we speak about the long pressure, we must understand that more than 5 or 6 hours. If we speak about the pressure power, you must understand that which things must pressure it on our patient's extremities or maybe cavities. Somebody woke up? Okay. It's usually happening after maybe some road accidents, after some car crash. It's some parts of our buildings, it's walls, roofs, some parts of our country, of our cars, and something else. It's a more powerful pressure on the patient's extremities and the patient's tissues. And if you speak about the definition, you check this definition on your screen now, you understand that some pathological changes or some pathological disorders which told us, which describe us the pathophysiology of this definition, it's some other problems, secondary problems in the respiratory systems, in the urine systems, and others. That's why the crash syndrome generally, it's maybe we named it like a composite, or maybe it's a number of different disturbances in the different patient systems, dependent by some outside accidents. I try to show you any pictures for you to understand what can cause the crash syndrome. Yeah, if somebody of you like a cars, you check what's happened with this, I think so, Ferrari, maybe a Lotus, in this picture, and you check what's happened with this building. We understand that this totally disturb of the buildings happened at how? Maybe it's some earth shaking in a seismo-active parts of our planet, non-afraid in Russia. When you're present now in Kursk, non-afraid about earth shaking, we have just one seismo-active part of our country, and these things present where in the east near the Vladivostok, near the Japan. That's why here non-afraid, but who rent the apartments in the Deriglazova, Pobeda and others, let's afraid because the quality of those buildings is not so cool. My congratulations for you. Who live in a hostel, you are the best. That's why this so big disturb of any structures, any materials guaranteed that first of all so high pressure power present on our patient, and secondary the long period of exposition. For example, let's try to take off any driver from this totally broke car, or let's find any disturbed patients who present under these constructions of the buildings. That's why, and here I think that you agree with me that nowadays too much of car crashing happening, in all streets, in all countries, in all roads, and too much of broken buildings we can check every day. Why? Because any nature accidents happening not so fast, but first of all, Greta Thunberg told us that our climate change, that's why all of us, we are dying. So positive future, yeah? And sometimes any small or maybe not so small wars happening anywhere. That's why too much of damaged persons we can find into these conditions. That's a good day. If we speak about the historical part of this of this term, firstly we start to speak about the crash syndrome in the First World War. Our last century have too much of big wars, and the science, generally the science increase her knowledge in all pathophysiologies, things and something else. I think that you agree with me that the best and the great investigations in the medicine happened in the last century. Too much of mechanisms we start to understand, too much of pathophysiologists we must understand, and that's why too much of definitions of new terms we start to check in the last century. In history, all scientists decide that maybe the great, and I agree with them, that the Great War is a Secondary World War, but too much of new weapons, too much of some other poisons and something else are started to use in the First World War. And too much of broken buildings, too much of broken souls happened in the First World War II. Too much of films based on the results of First World War, for example, Peaky Blinders serial, depended by the psychologist changes in the main actor who finished the First World War. That's why near than 1 century of crash syndrome definition. But they start to name this condition like this, and maybe not understand totally pathophysiologist of disturbance changes in the patient's body. But 1 century, our congratulations. Crash syndrome or SDS pathogenesis based on some special biochemical changes. For example, all of you know that all our muscles, it's and maybe all our bodies, 18% it's water in the different conditions, and more than 20% of our bodies are proteins. And our muscles include the myoglobin special vessel, the special protein. What's happened if we try to describe the pathogenesis of SDS syndrome? What's the main thing? All of you, you know that we have some changes like ischemia. If we speak about the critical ischemia, so fast and so hard ischemia, the final results we can check here after a few hours. What does it mean? Critical ischemia, maybe for example of the cardiac muscles, infarct. Critical ischemia of the distal parts of any extremities, gangrene finally, and totally and maybe deep and final necrosis of all tissues there. And the main anatomy mechanism in a SDS, it's a I forgot this term in Russia in English now. It's a ischemia. But if you speak about the definition, if you speak about the gangrene, it's a fast, total, maybe uncompensated ischemia. If you speak about the crash syndrome, it's a subcompensation ischemia of distal parts of any extremities or another cavities which layer below the area of compression. What does it mean? For example, our patients after some earth shaking presented under the wool, and this wool presented into her mid shaft of forearm. or of the femur, let's decide like this, more colorful. But he rests there like this, that critical ischemia in the distal part of your leg don't happen. He have a compression of artery and veins. That's why distally we have a some compensated ischemia, and this ischemia non-transform himself to the gangrene. But this hypoxia of the tissues, usually it's a muscles, because which organs we have on extremities? Muscles, vessels, and the bones, and that's all. That's why this subcompensated ischemia guaranteed that any disturbed processes into the muscles starts to grow. We don't speak about the total necrosis. We speak about the rhabdomyolysis, or maybe it's some special mechanism when we start to see any products of muscles disturbed. Few minutes ago, I told you about the structure of muscles. And here on this slide, you can see the word myoglobin. Myoglobin is a special protein which includes any muscles. In a subcompensated ischemia, this myoglobin starts to, first of all, product, and secondary starts to present where? Into the vessels. And another histamine, serotonin, and other polypeptides, which normally presents into the muscles, but into the subcompensated ischemia starts to present where? Into the vessels. Don't forget about this first introduction definition. These things help us to understand total mechanism of crush syndrome. Our patients process to present there under the wound. How much time we need for check the myoglobin into the vessels? None more than our previously period of longer compression, none more than 4 to 5 hours. After that, after this period of ischemia, we start to see these products into the vessels. But don't forget our patients present under the wound. And where all of these proteins concentrate distally than the line of compression. And if we try to check the concentrations of them, all next hour of this longer compression, the concentration of myoglobin usually increase twicely into the vessels. And don't forget that all of these products rest there distally than the line of compression. When they make the emergency services arrive in the place of accidents, they start to find these longer compression patients. And after 5 or 6 hours of this compression, they find this patient. This patient have a crush syndrome nowadays? No. This patient have a longer compression of the lower extremity in the mid shaft of femur, and this patient have a myoglobin into the vessels distally than a line of compression. Nowadays, now time in this second, the patient haven't any crush syndrome. After that, emergency services, maybe how we name this in English, uncompressed, or maybe unpack this patient under these parts of the building. Take off this long compression agent. Into the second, crush syndrome starts. What's happening? This higher concentration of myoglobin, which composed or maybe stay distally than the line of compression, starts to present in all vessels of our patient, because we reduce this compression and start to see if before that we have a local myoglobinemia, in the second, the general myoglobinemia starts to present. That's why I think that you agree with me that before any uncompression of our patient, if we have a longer compression and high power compression, we must protect our patient for general myoglobinemia. How? Let's apply the tourniquet upper the line of compression. And like this, when you uncompress your patient, you protect your patient for generally myoglobinemia. You non-stop the crash syndrome develop, but maybe you win some time for any traffic problems, for any transportation patient to the hospitals and something else where you can treat the crash syndrome more fully. Usually, this longer compression according by the any disturbance of any tissues. Maybe the patient has some wounds which present below the line of the compression. But from these wounds, the patient can lose some part of her fluid. Which kind of fluid? The blood. Or usually the patient loses just her fluid part of the blood, just plasma. We name it like plasmorrhagia. And we start to check what? We start to check the gamma concentration. This condition so dangerous for our patient. Why? Because when we uncompressed our extremity and unapply the tourniquet, the concentration of myoglobin in a gamma concentrations conditions increase more higher. Because the same number of myoglobin present in the more lower volume of the blood. That's why the concentration of them increase more faster and higher. Else, you try to understand. That's why the myoglobin. I told you about this sometime in the future about the next steps in the pathogenesis. Here, let's decide the diagnostic criteria of crash syndrome. It's for diagnostics. First of all, we try to check that big muscles are pressured so long time. If, for example, the patient pressured her second finger for a long time, which muscles you can see it here? Nothing, just tendons. That's why if we have a longer compression of any parts of our fingers, we have not any high concentration of myoglobin into the patient's vessels. Secondary, that's why usually it's a femur, tibia, maybe proximal part of upper extremity and some others. Else, we must find the hemoglobinemia, myoglobinemia. We check the biochemical analysis. You must understand that these criteria you can use when your patient present into the hospital. Before that, no. Yeah. And the creatinine kinase concentration more than 1,000 units. I told you about this in the future. Why? Because firstly, let's remember to maybe anatomy, but let's turn to anatomy department. And let's remember where all blood in our patient and our body are filtered. Where? In the kidneys. And the size of our kidneys canals, same like maybe more bigger than the size of erythrocytes, the most important cells into the blood for transport the oxygen, for reduce the ischemia or maybe hypoxia. Else, and if we check the myoglobinemia, that's why too much of new proteins starts to present into the blood, into the vessels. And let's remember the department of biochemical. All proteins, it's a so big molecules. Yeah, that's why it's too much of polynucleotides. That's why the size of proteins so big. And the size of myoglobin molecule more bigger than the diameter of kidneys canals. What's happening finally? We see the obturation, maybe total or subtotal obturation of the kidneys canals. That's why creatinine kinase concentration increased. Why? Today I spoke with my group about the kinds of the urine. Don't forget that we have two kinds of urine, primary and secondary. And the secondary urine you produce in a hot party when you drank too much of beer and you want to pee too much per evening. But it's a secondary urine. The primary urine, it's firstly concentrate into the kidney canals. The volume of this urine more higher than secondary. And if our patient's kidneys are obturated by the myoglobin, that's why the filtration function of the kidneys decreased totally. One of the most important kidneys filtration indicator into the blood, it's a creatinine kinase. The normal number is near than 100. And in this diagnostic criteria, I told you about the 1000. That's why generally the clinical maybe features of Crash syndrome dependent or maybe based on acute kidney dysfunctions, dependent by the previously level of myoglobin, and the previously level of myoglobin dependent by the area of compression, how much muscles are pressured before. And second, dependent by the exposition, how much hours the patient present under these compression agents, dependent by the previously conditions of her kidneys, and dependent by the any logistic things when the emergency services take off this patient under this contraction and transport to the hospital. If we speak about the clinical things, maybe more later clinical things, which starts to check after 24 hours of patients present into the hospital. Yeah, you see that maybe our patient have oliguria. That's why the patient can't produce any secondary kind of urine. And maybe you can check the higher increasing of any biochemical markers of kidneys filtration. It's a creatinine and the urine level into the blood. And you can find the myoglobinuria. Why? Because some molecules of myoglobin can filtrate into the kidney canals and go out urine system with the urine tube. That's why all of these things told you about the acute kidney dysfunction, about the syndrome of acute endogenous intoxication, and sometimes we can name all of these syndrome complexes like a polyorganic disturbance. If you try to classify the Crash syndrome, depending by the international classificator of any diseases, you can find that we have different, sorry, it's so hard to speak too much time per day. They try to classify it how? If the main pathogenesis processes the same in all kinds of the Crash syndrome, we can classify him dependent by the previously localization of lung pressure, and that's all. That's because the pathogenesis in all of these cases are same. If we try to classify it by localization, head, breast, abdomen, pelvis, and limbs, but usually I told you I checked the Crash syndrome in my 10 years practice twicely. Maybe it's depend by the, and why maybe? It's dependent we live in a not so, in a so quiet city, I think so. We have not any criminal parts, we have not any disturb of the buildings. And generally, I like that I live here, and my congratulations for you too. That's a short period of your life you live in a so quiet region. By combination with the damage, sometimes longer compression happen. It's when we have a fracture of any bones, for example, mid shaft of femur. Longer compression, distal increasing of myoglobin levels, and the fracture of femur too. Today it's a mixed form of crash syndrome, and today in my group we describe the the femur's fractures. And don't forget that if our patient have a fracture of femur, according by the crash syndrome, he loses 1 liter of blood. That's why if you have a fracture here, if your patient have a fracture here, the high level of myoglobin or EMEA starts faster. By severity, light, average, and heavy, and by the clinical period. It depends by the compression period, post-compression period, early. It's a one. Too much of authors give you the different time and period. Why? Because they decide like this. If you prepare the new book, what's more simply for changing? How you can change anything, and let's told anybody that it's in a new book. Let's change the period of time, and then that's all for 2 days more, longer or early. That's why intermediate and late, more than 18 days. And I told you that the most dangerous for our patient, it's a post-compression period and early. If our patients stay alive into these periods, generally prognosis for them, maybe you can name like, well, long-term compression can be complicated, maybe, or maybe you can see the according by the burns, by the frostbite, by the radiation damage, and by the poisons. It depends where this accident happened. For example, how much years ago this tsunami happened in the Japan region when the Fukushima station nuclear station broke. That's why if somebody have a crash syndrome or syndrome of longer compression, there maybe we can see the according radiation damage. Too much of you watch the HBO serial about Chernobyl, and I think that if something happened in Russia, usually we can check this syndrome with the frostbite. Why? Because you understand that near than 6 or 9 months in Russia, we have a so-called weather outside. And if we have so long compression, usually we can check according to frostbites distally too. Might develop complications if we have all of these complications dependent by the endogenous intoxication. You can find it. Myoglobin, it's a poison for us, but not so acute, for example. All of this endogenous intoxication dependent by the fast and terminal losing of the kidneys functions. That's why our body tried to fixate all of these poisons in the kidneys, but the kidneys don't work. That's why endogenous intoxications increased. And finally, we can find the purulent septic problems. Why? Because this acute kidney dysfunction can transform in a purulent abscess in the kidneys. And after that, we can see the purulent metastasis in any parts of the patient's body. And sometimes, the crash syndrome finally according maybe by the sepsis. When I started this lecture, I told you about the applying of tourniquet. You understand that when you apply the tourniquet, don't forget, and I have this picture after a few slides, don't forget that you must insert some information, which information, in which time you apply this tourniquet. All of you know the rules for temporary stop bleeding when you apply the tourniquet, how much time this tourniquet can spend on your patient. You know that in a warmer period of the year, not more than 1 hour. And if it's so cold outside, not more than 30 minutes. It depends by the speed of critical ischemia distally. Let's turn to our situation. The compensated ischemia developed 5 hours before you apply a tourniquet. That's why the timing of this tourniquet using more shorter than when you want to stop a bleed. 30 minutes, not more. Why? Because after these things, the critical ischemia starts, and you can't save the patient's extremity usually if the necrosis starts distally. You must amputate them immediately. That's why don't forget, when you apply the tourniquet, the clock starts to do and you must transport your patient to the hospital. Another question, when your patient present in the hospital, how much time the tourniquet can spend on your patient? Not any another seconds. You must take care of this tourniquet, and post-compression period of crash syndrome starts. That's why you start to see all biochemical changes. You start to see myoglobinemia. You start to see that the patient's kidneys work not so well. You start to see all symptoms of endogenous intoxication. How to reduce all of these clinical things? First of all, you try to dilute the blood. You try to dilute the blood. How? You start to fast injection of gamma dilution solutions. What is it? The main of them is an isotonic solution. Generally, you know what does it mean, isotonic solution? It's just sterile salted water, and your osmotic pressure the same like our tissues. How much? It's depend by the too much of internal and external conditions. Depend by the level of myoglobinemia, depend by the general condition of your patient, depend by the biochemical levels of kidney dysfunction, the level of urine and the level of creatinine. And depend sometimes maybe how it happened in the real life. Too much of injured patients and not so high number of the doctors. That's why sometimes this detoxification therapy or maybe gamma dilution therapy control who? Nurses usually. But you must prescribe him that for dilute the blood, you must inject in the first 2 or 3 hours after compression, near than 3 or 4 liters of this solution. Other problems. You don't know what's happened with the previously kidneys condition into your patient. That's why myoglobin obturate the kidneys canals and you non-stop your infusion. You non-stop your infusion and infuse new liters. That's why the speed of kidneys filtration must present in a high level. But how the kidneys can filtrate all of new liters of detoxification therapy if all kidneys canals are obturated by the myoglobin? Problems. That's why after some hours of this treatment, what's happened? The kidneys stop to work finally. That's why this detoxification of our patient by the forced diuresis method. How? We inject more volume of the fluid and try to evacuate all of this fluid by using of diuretics. And the function of our kidney is not so well. That's why forced diuresis don't work in this situation. And how you can, it's just base for you. I read the lecture up at this slide. And how you can filtrate the myoglobin from the patient's blood if you can't use the native filters for the blood, like a kidney. In this situation, we must use the external methods of blood filtration. The best of them is a hemodialysis. Like this, we can filtrate all maybe the highest volume of presence in myoglobin into the vessels. Like this, we non-decrease the kidneys function, we non-inject another fluid into the patient's vessels, and finally non-check any general edema or NASAC. Don't forget that we must make the oxygenotherapy, because if we have a myoglobinemia, that's why the patient have a gemic kind of anemia. Maybe myoglobin can fix the non like a CO2, yeah, but the myoglobin can connect with the hemoglobin, and like this we maybe sometimes have a normal level of the erythrocytes, but the erythrocytes can transport to normally volume of the oxygen. That's why we can see what normally levels of any results in the blood analysis, but finally we have a general hypoxia. That's why we use the adequate oxygenation, and that's why we protect the patient. If the patient have wounds, we protect him by any anaerobic kinds of infections. Don't forget that we must treat, and this is first of all where our patient present in the reanimatologist department, and we must cupate all syndromes that our patients have. Yeah, we must treat her wounds. We must stop the bleeding temporarily or generally. We must fix it all her injured extremities. For example, if the patient have a fractures, if the patient have any subluxations and something else. Like this, we can stabilize her general condition. And this is a picture. Don't forget about the time when you use the tourniquet. Why? Because maybe this, in which situation we can see you're a single doctor and you have too much of patients around of you, and maybe you can forget how much time ago you applied this tourniquet for this patient. If you speak about the you check maybe if you speak about the pathogenesis treatment, let's turn to the anatomy department and let's remember how the muscle structures. All muscles, all volume of the muscle are covered by her fascia. This fascia, maybe it's like a capsule for any muscles. When their muscles, when we move this fascia, told us that guaranteed. So we have a normally maybe space form of the muscles. That's why. And if you understand what does it mean, the fascium is so strong and so soft tissue. It's not so elastic. That's why if we have some compression under the fascium, and this compression guaranteed that we have a myoglobinemia. When we have this compression, we have some retraction of this fascium. And what's happened? You uncompressed your patient under these rules and something else, but under fascium compression pressure non-decreased, and this tension of fascium guaranteed new molecules of myoglobin developed there under the fascium. That's why I start from the First World War, and if the definition we start to check there we have a first methods of treatment. Nowadays it's a historical method of treatment. Why? Because we name this method like fasciotomy. Fasciotomy, it's a decompression of muscles. We made the approach on this pressured muscle, approach so deep, we cut the skin, subcutaneous fat, general fascium, and made the approach on this compressured muscle. And after that, the muscle go out. Like this, we uncompress the muscles and decrease the production of new myoglobin. Well, decision, maybe yes, but first of all, If we speak about the First World War, it's a pre-antibiotic period of our history. And how much of this fasciotomy you must make? And all later for extremity, for uncompressed all muscles. That's why you made too much of approaches. Where? Maybe in a field hospital. And it's a cool entrance and a cool conditions for any infections. Because maybe you can cover this approach or maybe fasciotomy by some aseptic bandage and something else. But you don't protect your patient for late purulent problems. Maybe anaerobic and maybe some special kinds of infections. You increase you can't do anything with the previously acute kidney dysfunctions. You just reduce the future level of myoglobinemia, and that's all. Maybe if it's happened, I don't know, so far, and you have not any dialysis departments near than you can use this fasciotomy method. But nowadays, please, if you can, let's treat the crash syndrome by the new and actual methods of treatment. Let's treat him dependent by her pathogenesis. Non-fatty, I don't want to speak about this else. Treatment, acute. If you speak about the treatment of kidney dysfunctions, nowadays, it's so cool when we have a determined of medical specialists. Usually, maybe if now any of these patients admitted to our hospital, who occupy any problems in the kidneys or maybe any problems in the blood? Reanimatologists, not us, not traumatology, because I told you 10 minutes ago about the high intravenous injections of crystalloid solutions. But don't forget that so low and so volume infusion guaranteed that acidosis in our patient's body starts after a few hours. That's why we use this some buffer solutions. It's a 4% solution of sodium bicarbonate, glucose and others for change the pH of our patient's blood and pH of our patient's tissues. If our patient had a previously bleeding, we inject him accordingly. Don't forget that nowadays we don't